All right, this is chapter 13, lower gastrointestinal system, from the 11th edition of the textbook of radiographic positioning and related anatomy. This is small bowel series, small bowel follow through, enteroclysis, and the intubation method. So this is starting on page 500. This is figure 13.1. And literally, chapter 12 was all about from the mouth through the duodenum. And then chapter 13 includes the entire small intestine and large intestine. This particular chapter is about the small bowel series and all the small bowel imaging that can take place. A lot of times with this particular exam, it can follow an upper GI series, meaning they can order an upper GI and a small bowel series, and that is actually called a small bowel follow through. When we look at the small intestine, I can tell you that this is a functional study, meaning that it is timed. And that is how they test the function of the small intestine to make sure that everything is going through as it should. So you can see it says that it frequently follows an upper GI series, and it does require oral contrast media because in order to see the intestines, you have to have some kind of contrast media in order to make those stand out. So in this particular radiograph in 13.2 on page 500, you can see the remnants of the contrast that are in the stomach. Then it would come through the duodenum. It would go through the jejunum, which is the feathery part of the small intestine, and then ends up in the ileum and goes into the large intestine. When we look at the location of the small intestine, we have the duodenum that occupies the right and left upper quadrants. We have the jejunum, which is mainly in the left upper and left lower quadrant. And the ileum, with the spelling of I-L-E-U-M, takes up the right upper, right lower, and left lower quadrant. And then the ileocecal valve is typically found in the right lower quadrant. So the duodenum is the shortest and widest segment. It's about 10 inches in length. The jejunum makes up 2/5 of the small intestine, and it has the little villi in there that appear feathery or like pillow stuffing. And then the ileum is the last section of the small intestine, and that is, notice the spelling I-L-E-U-M versus I-L-I-U-M, like in the pelvis. That makes up 3/5 of the small intestine. And then once it gets to the terminal portion of the ileum, it passes through the ileum into the cecum, through the ileocecal valve, which is found in the right lower quadrant. Some of the differences between the small intestine, you can see this figure 13.5 on page 501. Like we said, the duodenum is the shortest but the widest segment, and it's approximately 25 inches in length. The jejunum makes up 2/5 of the small intestine, and it has a coiled spring or feathery appearance over here. And then the ileum, spelled this way, makes up 3/5 of the small intestine, and it's the smallest in diameter. So it goes from the widest to the narrowest in the last section of the small intestine. And they do show you the quadrants so that you can see where the bulk of that small intestine is. Now, the small intestine is approximately 15 to 18 feet while the patient is alive. And then upon autopsy, it tells us that stretched out, it averages approximately 23 feet in length. And that's because there's no muscle tone on autopsy. But with muscle tone, when the patient is alive, it's approximately 15 to 18 feet in length. It does note that over 100 autopsies on average, the small bowel ranged in length from 15 to 31 feet, which is kind of crazy when you think that if you stretch that out, it would be 31 feet long. Some of the differences between the large and the small intestine. The main differences are the internal diameter. Typically, the small intestine is smaller in diameter than the large. The large intestine is pulled into pouches, which are called the haustra, and they're pulled into those pouches by the Taenia coli. Those are the 3 longitudinal muscle bands that pull the large intestine into these pouches that we see here. And as far as location, typically the large intestine lines the periphery of the abdomen, and the small intestine occupies the middle section of the anatomy. This is referenced on page 503, figure 13.12. So typically the internal diameter of the large intestine is greater than the small bowel. The large intestine is pulled into haustra by the 3 longitudinal muscle bands called the Taenia coli. And then the location where the large intestine is around the periphery of the abdomen and the small intestine is in the middle. All right, one of the first imaging exams that we have of the small bowel is called a small bowel series, or sometimes you'll see that referred to as an SBS. When we look at the small bowel, notice that as far as function of the intestine, typically digestion and absorption takes place in the small intestine, and then reabsorption and elimination takes place in the large intestine. So most of your absorption does take place in the small intestine, and that is the absorption of the nutrients, salts, and proteins tends to take place in the small intestine. When we look at a small bowel series or an SBS, some of the clinical indications or the reasons why a patient might have this could include enteritis or gastroenteritis, meaning inflammation of the small intestine or inflammation of the stomach and small intestine, Meckel's diverticulum, a neoplasm, malabsorption syndrome, meaning that there is not good absorption, or ileus, which is a mechanical obstruction, and it can be either adynamic or paralytic. Okay, those pathologies are they start on 506 and they continue through actually 508. One thing I do want to point out, this cobblestone appearance in Crohn's disease or regional enteritis, if you look at the chart on table 13.4, where they list the condition or the disease, and then they tell you the most common exam that is done and the possible radiographic appearance, some of the things that you probably want to make note of, if you look at regional enteritis, it talks about the cobblestone appearance or the string sign. Okay, and then under the ileus, there's giardia. I do not say this word well. Giardiasis. I cannot say that, but that is a dilation of the intestine with thickening in the circular folds. The ileus, there are expanded loops of small bowel, and a lot of times they'll tell you it has like a circular staircase, like this, the circular staircase, or a herringbone pattern. When they point out those signs like the herringbone or circular staircase or Meckel's diverticulum, okay, so on there, if you look at Meckel's diverticulum, the neoplasm, it talks about an apple core or a napkin ring sign. Anytime you see in those charts where they put in quotations the sign, like an apple core sign or a napkin ring sign or cobblestone appearance or Schatzki's ring, those are things you probably want to add to your note cards or flashcards on your pathologies, because those are the things that the registry loves to ask you about. If you see a Schottky's ring, or if you see a cobblestone pattern, or if you see a staircase pattern or an apple core sign, those are the things they tend to target. So go back through on the esophagus and on the stomach and look at those things that they mention on there, especially on the charts that are listed in the chapter after the pathologies. Like on the upper GI, they mention for gastritis, it has a speckled appearance. The hiatal hernia has a Schottky ring. Ulcers have a halo sign. Those are the things that you want to put on your note cards so that when you're reviewing at the end of the program, those tend to be the things that you will find they ask about on the registry. Some of the different small bowel procedures that we do, there are different things. So they can order what's called a small bowel series or an SBS, and that is an exam that looks at just the form and function of the small bowel. Sometimes they can order what's called an upper GI small bowel combination. Usually it's called an SBFT, and it's small bowel follow through. That is a complete upper GI followed by a complete small bowel series. They can order what's called an enterocolysis, and that is the only double contrast study of the small intestine. And then they could also order what's called an intubation method. And with the intubation method, there are two types. There's either a diagnostic intubation method or a therapeutic intubation method. Okay. On the contraindications, they are the same as any other fluoro study that we've talked about or barium study that we've talked about. The contraindications to barium would be if they are having or had surgery within the 48 hours, meaning they're having it within 48 hours or they've had it within 48 hours. If there is a possible perforation or if there is a possible obstruction, then those would be contraindications to giving the patient barium. Contraindications to the water-soluble iodinated contrast media, typically they will not give that to very young or dehydrated patients because it tends to increase the dehydration, and they will not and cannot give that to patients that have a sensitivity to iodine. If they have a severe allergic reaction to the iodine, then the patient could not be given the water-soluble iodinated contrast. So those are contraindications. Reasons you cannot give water-soluble would be young, dehydrated, or iodine sensitivity. Reasons you cannot give the barium would be pre or post-surgery, 48 hours, a possible perforation, or a possible obstruction, just like we've had when we've talked about those in the past. The patient preparation for a small bowel series, this is actually found on, let me flip through here. Sorry about that. The older edition, it's a little more challenging to find this. Clinical indications, contrast media, a whale, small only. Basically, the patient prep for this is, I do know it's in here. I just, for the minute I'm in here, I'm not finding that right off the bat. Contrast media. The patient prep for this is they are NPO for 8 hours prior to the exam. Yep, still looking, still not finding it. Okay, NPO at least 8 hours. They typically follow a low residue diet for about 48 hours, meaning they're told to be careful of what they actually eat. There's no gum chewing, no smoking, and as always, we would ask about pregnancy just to make sure that if the patient were pregnant, we would not move forward with that exam until we were told to do so. A lot of times, depending on what's going on with the mother, that would determine whether we move forward with the exam or not, if there was a possibility of pregnancy. As far as the room preparation, it's pretty similar to any other room prep that we have with a fluoroscopy study, meaning that we would I know this picture has the IV pole with the barium bag, but not counting that because that would be for a barium enema. You would get the table prepared, you would have your fluoro tower prepared, you would have your contrast media prepared, you would have any image receptors that you were going to use, and if you were doing an enteroclysis or the intubation method, you would also have to have the catheters that would be necessary for that. Actually, on page 511 is where that patient prep is. 511, about halfway down on the left column, it says the patient prep for a small bowel is identical to an upper GI. The most common study consists of a combination of two of those. One long exam looking at the upper GI and then the small bowel. The goal is always an empty stomach. So typically food and fluid is withheld for at least 8 hours. Ideally, they're on a low residue diet 48 hours prior, and no tobacco or nicotine products, no gum chewing. And the patient is typically always given a scout image to be looked at and verified prior to the exam beginning. Now, the small bowel only series. This is on page 510. And this literally is telling you what our protocol is for a small bowel only series. So we do a scout radiograph, which is an AP supine abdomen, just to see what everything looks like in there before we begin. The patient is then given 16 ounces of barium, and we have to note the time, write that down, when they finish drinking the barium. So typically when you give the patient the barium, you're asking them to drink that fairly quickly. I usually give them a maximum of 5 minutes to drink all 16 ounces. Some patients will drink it quicker, some will try to drink it a little bit slower, but when they drink it slower, it tends to spread out a little bit in the stomach and the intestines. So I would try to ask them to get that down within a 5-minute time frame max. Once they finish that, we will do a 15-minute radiograph, meaning if we mark time when they finish drinking, and let's say it was at 8:30 a.m., then at 8:45, we would do a 15-minute radiograph, and the patient may be laying on their back, so we do an AP view. 30 minutes after they finish drinking at 9 a.m., we would do a 30-minute image, and we would flip the patient over PA, so they're prone. At 9:15, we would do a 45-minute radiograph and put them back on their back. And at 60 minutes, so at 9:30, we would do a 60-minute image with the patient prone. Now, why do we flip-flop these? I usually say that a small bowel is flip-flopped supine abdomens. The reason for that is when you put the patient PA, it actually uses the patient's own body weight to separate and spread out the loops of bowel. So if you started the 15-minute PA, you would do the 30 AP, 45 PA, 60 AP. It does not matter how you start them as long as you flip-flop between images. So we do, regardless, we do 4 images 15 minutes apart, and after those 4 images are done at 60 minutes, we check if the barium has reached the ileocecal valve, Then we go ahead and take a spot, not we, the radiologist comes in and we take a spot image of the ileocecal valve. And that image would actually look like, oh, let me find this. I don't know why this particular book, they made it so crazy. The spot image of the ileocecal valve is all the way back on 504, figure 13.16. They show you an amazing spot image that D is the terminal ileum in that picture, E is the ileocecal valve, and then they label the cecum. So that's what the radiologist is trying to get, is an image of the ileocecal valve, because a small bowel only series is deemed complete when barium passes through the ileocecal valve. If barium doesn't pass through the ileocecal valve, the study is not complete. And in this particular image, they do show you a 12-inch parasitic roundworm in the jejunum, which is right here. It's kind of disgusting to think about that, but that's what that image shows. And I don't, let's see if I can find that in here. That is figure 13.57 on page 526. Okay, so that is our routine. Once we finish the 60, we check. If we're at the ileocecal valve, then we set up for fluoro and they take a spot image of the ileocecal valve. If we're not at the ileocecal valve after 60 minutes, then we're typically told how long to wait to get another image. It could be an hour, it could be 2 hours, it could be the next day. It completely depends on where the barium is in the patient's system, because remember, this is considered a functional study. Okay? It's functional because it's timed. That's the biggest thing. When it's timed, it's considered a functional study. This AP or PA projection is on page 527 of your book. We do a 15-minute radiograph, but notice in the book they usually will tell you that it could be 15 or 30 minutes. It completely depends on protocol at your facility. The SID is 40 inches. You are on a 14 by 17 portrait. If your patient was hyperstenic, it is possible you would do 2 images landscape. Your KVP range is 110 to 125 for single, 90 to 100 for double, and or water soluble. I recognize the book says lower, but I'm going to tell you that we rarely go below 90 when we have the water soluble contrast media. The technique on either, if you do an AP or a PA small bowel image, your technique is 110 at 2 for single, 90 at 2 for double or water soluble. Now, they tell you that the central ray is 2 inches above the iliac crest at midline. Okay, now that would be if you were on one IR portrait. If you were doing 2 images landscape, then you would just include pubic symphysis and then have your 1 to 2 inch overlap. Central ray perpendicular to iliac crest and midline, or if you were doing 2 images landscape, you would include pubic symphysis on the first with 1 to 2 inches of overlap on the second. Actually, I might have misspoke and said page 527 for the AP or PA small bowel. I apologize. It's 525 on that. Okay, so 525 shows you a PA small bowel, but there's no reason you couldn't do it AP. So the technique is 110 at 2 for single, 90 at 2 for double or water soluble. Notice it does tell you that you have to use time markers, so it would have to be annotated with a 15, 30, 45, and 60 minutes. And the central ray is perpendicular 2 inches above iliac crest at midline for the 15-minute film. All other, the 30, 45, and 60, are going to be at the crest and midline, just like this says. 15 minutes, 2 inches above iliac crest and midline. All other images are going to be at iliac crest and midline. That's assuming you have one IR placed portrait. If you have 2 IRs placed landscape, then you would include pubic symphysis and have a 1 to 2 inch overlap between both images. Okay, and remember, time has to be noted after the patient finishes their second cup of barium, because they consume 2 8-ounce cups or 1 16-ounce cup of barium for this procedure. This is showing you when you place the patient PA, it does separate the loops of bowel better because you're using the patient's own body weight to separate. So you can see there's still barium in the stomach and the fundus. You've got the body and the pylorus. Here you have the duodenum, the jejunum over here, which has a feathery appearance. And then you've got the ileum over here, and it's started to go into the ascending colon. You can see they have right marker. We would use left, and they do have it marked as a 30-minute because it is a functional study. You should always demonstrate the entire small intestine. Typically on the 15-minute radiograph, you will also include the stomach so that you are able to see where the contrast media is in relation to the small intestine. On all the other images, you want to make sure you have the entire small intestine as well as time markers visible. Now, we don't tend to use markers, but they will annotate the images. So you'd want to annotate with 15, 30, 45, and 60. And anything you do beyond that, you would also annotate the amount of time that has passed since they finished the second cup or all 16 ounces of barium. They typically will use fluoroscopy with what's called a compression cone, which is this right here, or they can use the compression paddle where they will push down against the patient's stomach. This is figure 13.25 on page 510, and they'll actually push on the patient's stomach to get that image of the ileocecal valve. This is that picture that I mentioned before at the, let's see what it is. I think it's the back of this chapter. The way they've got this is so screwy. Figure 13.6 on page 526 is this. So you've got the ileum passing through the ileocecal valve into the cecum. So this proves that the entire small intestine was visualized, and that would deem the study complete. You can see this is a PA 2-hour image. You can see there's still barium in the stomach, but then you've got the jejunum and the ileum filled with barium, as well as starting to go up the ascending colon. So they would take a spot image of the ileocecal valve to prove that that study was complete. And that is a small bowel only series, or an SBS. Another exam they can order is what's called an enterochalasis, and this is on page 510. This is the only double contrast study of the small intestine. And some of the indications for ordering this would be if they had an ileus or a small bowel obstruction. The patient could possibly have Crohn's disease, or they could have what's called malabsorption or bad absorption syndrome. If they order an enterocolysis, basically they would place a catheter into the patient that has a guide wire. This would be done under fluoro. They would pass the catheter into, typically into the patient's nose, down the pharynx, through the esophagus, into the stomach, all the way through to the duodenojejunal flexure, meaning through the duodenum into the first part of the jejunum. Typically then a thin barium mixture would be injected through a syringe, through that catheter, into the jejunum. And then since it's a double contrast study, not only would you have barium, but you would use air or what's called methylcellulose injected into the small intestine as well. And that gives them the double contrast effect. Typically they use the methylcellulose because it sticks to the wall of the bowel while it distends it. Typically there are fluoroscopy and radiographic images taken. Usually the patient is not very comfortable for this exam, and there is the possibility of perforating the bowel when the catheter is being placed. Okay. Once they get the images that they need and they've proven what they need to, then they would remove the intubation tube. And like we said, there is possible images taken of that patient. This is actually figure 13.26 on page 510. There's also what's called an intubation method. This is referenced on page 511. And there's two types of intubation procedures. There is what's called a therapeutic intubation, and that is typically done to decompress the small bowel. It relieves the patient of either gas and or excessive fluids. And they pass a double lumen catheter into the stomach. And a lot of times with the therapeutic, it's not really about the images, it's more so about relieving the gas or the distension that is in the patient. The diagnostic intubation, however, that typically is called a small bowel enema, and they place that catheter in the patient's nose, down their pharynx, through the esophagus, through the stomach, into the jejunum. And then typically they use the water-soluble iodinated contrast, and they inject it through that tube, and they take radiographs at timed intervals, similar to a small bowel study, except typically with the diagnostic intubation, the patient is too sick to actually ingest the barium, so it's placed in there through the catheter to the patient. So that is the intubation method. So there's two types. There's therapeutic intubation and diagnostic intubation. We talked about a small bowel only series and the enterocolysis method. And we also mentioned the small bowel follow through, which is a routine complete upper GI followed by a complete small bowel series. So in those exams, that patient is with you quite a long time, because you would basically, for a small bowel follow through, you would do your scout image, go through all the fluoro for an upper GI. You would do your overhead images, which are AP, LPO, RAO, right lateral. Once those are checked, you would give the patient an additional cup of barium, note the time when that cup was finished, and then do a 15, 30, 45, and 60-minute small bowel image all the way through until the barium has reached the ileocecal valve. As always, anytime a patient is given barium or water-soluble iodinated contrast, they will receive post instructions after the exam, which are to drink 8 to 10 glasses of water in addition to what you normally drink until your stool returns to normal color. Otherwise, it can harden in your intestines, and then the only way to remove that is surgically. So we try to impress upon them to drink the water to flush their system, just like if they had contrast for any other procedure. Okay, so this completes the study of the small intestine. Remember, there are 4 exams. There is a small bowel only series, which is a functional timed study. There is a small bowel follow through, which is a complete upper GI followed by a complete small bowel series. There is the enterocolysis method, which is the only double contrast study method of the small intestine. And there is the intubation method that can be either a diagnostic intubation or a therapeutic intubation. And all of this comes from chapter 13 of the 11th edition of your positioning book. Make sure you write down any questions you might have and bring them to class. And the next time we meet, we hopefully can discuss and clear up any confusion or any questions you have. Okie doke. Have a good night.